He will speak us on the impact of pharmacogenomics on epilepsy treatment, current status, and future perspectives. Professor Perucca.
Thank you very much. And again, thanks for the invitation to take place in such an outstanding meeting. I feel very much at home. We are so much behind schedule, and this is exactly what happens when we have a meeting in Italy. So this is perfectly aligned with my own culture. The previous speaker made a reference to a sexy topic, and genetics tends to be very sexy these days, though I'm not sure you will think the same after hearing my presentation today. So let's start by outlining before the dream, explaining why we need to look at genetic determinants of a response to anti-epileptic drugs. Well, we know that about 70% of people will respond to the first or to the second drug that we use. We know that about 15% discontinue the first drug because of idiosyncratic adverse reactions. And the big question is whether genetic information could help us in predicting both the therapeutic response and the adverse effects of drugs. And the dream that you saw before is that someday, and we are not there yet, obviously, we might identify genetic markers that could predict responsiveness to a specific drug that would allow, for example, us to select rationally a drug over another based on a specific genotype. Would be nice if we could identify through a genetic biomarker refractoriness from the very beginning. We'd be able to refer early patients to surgery. And importantly, if we were able to identify genetic markers for drug reactions, and for there, as you will see, we do have some data, it would improve the safety of the treatment that we use. So just to indicate the amount of interest that goes into such topics, if you type on PubMed pharmacogenomics and epilepsy, and you go, for example, for a period from 91, 2000, or 2001, 2007, or for the last 6 years, you see that really there is an exponential number of publications of this topic, and many, many people more look into that. So what are the findings that have emerged from all this activity? Well, theoretically at least, you may expect that pharmacogenetics could influence response to drugs in many ways by affecting the pharmacokinetics of a drug, by affecting the way a drug interacts with its target in neurons, or other ways, for example, by influencing the way neuronal networks are arranged or modulating factors. And we do have some data suggesting that genetics do influence the pharmacokinetics of drugs. I'm showing here one example of a drug which does show a pharmacokinetic pattern which is governed by genetic polymorphism, and that is phenytoin. It's a study done in Japan, and it shows, the study included a number of subjects, but it shows two extremes. This is the relationship between the phenytoin dosage and the serum concentration. It's a fast metabolizer. And this is the relationship between dose and serum concentration in a slow metabolizer. And we know that slow metabolizers have a specific genotype for 2C9 and 2C19, which are the two enzymes that metabolize phenytoin. Actually, in this specific study, they did not pick a subject with theoretically the worst possible genotype in the way of metabolizing phenytoin. But that subject stands in front of you. My genotype is for 2C9 is star free, and for 2C19 is also star free. So my phenytoin half-life is 120 hours compared with an average of 12 hours after a small single dose in the majority of subjects. So there is genetic variation. And of course, therapeutically, we can account for that by monitoring serum drug levels and adjusting the dosage accordingly. I will not spend much time on this, and I don't want you to look at, of course, and you cannot look at the details in this slide, but if you are interested, you can look into this publication, which is very recent, and you'll find all the references and all the information concerning the way genotypes mostly for different cytochrome P450 enzymes, but also for other enzymes as well, including UGTs, can modulate the pharmacokinetics of drugs. There are also some data, rather preliminary, indicating the pharmacokinetics is not just influencing drug levels of the drugs, but also susceptibilities to some idiosyncratic reactions. And here are some examples where, for example, hepatotoxicity, aplastic anemia from felbamate, skin reactions, and teratogenic effects have been suggested to be mediated by the formation of reactive metabolites. And again, there is some indirect evidence that that is under genetic control as well. And this may be one of the mechanisms by which some of the subsequent data concerning predictors of adverse drug reactions can be explained. If we go back some time, and this goes back before era of widespread pharmacogenomic studies, there have been several observations, especially in twins, indicating that genetic factors do affect, especially immune-mediated drug reactions. This is shown, for example, this is just one example. This is a publication of two twins that were given carbamazepine, and both of them developed exactly with the same time course and the same dose and the same reaction. So, and this is an observation repeated again, so indicating that these interactions are under genetic control. Where the big advance was made was when this paper was published in Nature. And actually, this is probably the most widely cited publication when it comes to pharmacogenomics of epilepsy, and it is one page. Actually, the entire article is less than one page because the same page also had other information. And basically, that page is extremely important because it changed the way epilepsy is treated in some regions of the world. Basically, the study identified a specific marker for Stevens-Johnson syndrome induced by carbamazepine. And this translated into the prescribing information in all countries of the world. This is one example for the US, but also EU has a similar, and other agencies have the same. So people who are positive for this specific allele basically should not be given carbamazepine because they have a very high risk of developing serious cutaneous reaction. And you may argue that there are pros and cons of this because it has somewhat resulted in carbamazepine being used less frequently in some of the populations that are susceptible to this reaction, and may be disadvantages in that because the test is not widespread in such countries. And those countries are, as each of you will know, of course, China, and the study initially was done in Taiwan, but actually, if you look at the prevalence of this specific allele, Han Chinese are not those showing the highest frequency. Filipinos have a higher frequency than Chinese. And I know, I mean, Thanos was telling me there's a large community of Filipinos in Athens, for example. And more and more people travel across borders. So be aware that, especially from people from South Asia, this genotype should be checked before starting people on carbamazepine. There was one study recently done in Taiwan where systematically they screened people for this genotype before prescribing carbamazepine. And what they found is that there were overall more than 4,000 subjects genotyped. 215 people were found to be positive for the allele, and they were not given carbamazepine. So when they looked overall at the number of people that in their study, these were people with newly diagnosed epilepsy that needed to start an anti-epileptic drug and in whom carbamazepine was considered, when they looked how many people developed Stevens-Johnson syndrome, or even worse, toxic epidermal necrolysis, 0, 0, 0. And they calculated that based on what we know about the prevalence of the risk, if the genotype was not done, then there would have been 10 cases of Stevens-Johnson syndrome. And there was one recent study done in Australia indicating that in people with epilepsy, of course, from those populations, and those are South Asian Asian populations in whom carbamazepine is contemplated, the number of adverse reactions saved by genotyping is actually greater than the number of lives saved by the ultrasound, mammary ultrasound in women below age 60. For Europeans are not susceptible to that reaction because in Europeans that specific allele, the 1501, is virtually absent, so there is no point among people of Greek ancestry to genotype for. What there might be a point is to genotype for this specific allele, which is associated with all kinds of cutaneous reactions from carbamazepine. This has been confirmed in studies from different European countries and from people of European origin and also from Asian origins in other countries. And basically what it shows is that for hypersensitivity syndrome, for a simple, which is obviously the most common, maculopapular exanthema, Stevens-Johnson syndrome, all genotypes together, people who are positive for this allele have a higher, much higher risk of developing an hypersensitivity reaction. And altogether, if the allele is present, the risk of hypersensitivity goes from 5%, which is what normally found with carbamazepine, to 26%. And it was also calculated that on average about 60 people would need to be genotyped to prevent one case of hypersensitivity. This may be less relevant, however, because Stevens-Johnson syndrome is a very serious condition that you want to avoid at all costs, I would say. A maculopapular rash, you wonder the cost effectiveness of preventing one maculopapular rash. If you want to know about this, I refer to this excellent publication which came out lately, in which they looked at all the data and they tried to calculate risk and make recommendations. And these are the recommendations who should be tested for 1501, individuals from ethnic groups where the incidence of this allele is high or unknown. Unknown is actually many countries, but if you look high, it would be China, India, Sri Lanka, Taiwan, the Philippines, and all the countries in Southeast Asia. The level of recommendation is strong. You should do it before prescribing carbamazepine. The sensitivity of the test is 80–97%. That means that if you don't do the test, 80 to 97% of the people with Stevens-Johnson will be found to be positive for this allele. And the positive predictive value is 15%. That means if you still want to do, which you should not, give carbamazepine to people who are positive, the risk of Stevens-Johnson can be as high as 5%. Others say as high as 7%. Still a completely unacceptable risk given how serious the condition is. For 3101, and this affects the Europeans, all individuals should be tested if you want to do the test. The recommendation is moderate for the cost-effectiveness issue that I mentioned before. The sensitivity is 26–61%. That is, those who develop a rash, 60%, between 26 and 60% will be positive for this allele. And if someone has a positive genotype, you would expect the risk of an allergic reaction, mostly a mild maculopapular reaction, to be in the order of 42%. The next question is, do those genotypes also predict serious hypersensitivity reactions to other drugs? And some data are accumulating that at least for some drugs, the answer is yes. For example, for phenytoin, again, this is 1502, the genotype that we are discussing in Chinese, you should not be using phenytoin because these subjects are also at increased risk from Stevens-Johnson and toxic epidermal necrolysis with phenytoin. And there are also preliminary data with broader confidence limits that also lamotrigine is a drug that is preferably avoided in those people, which is not surprising because we also know the cross-reactivity between these drugs. More lately, this is a paper that came out a few weeks ago, another genotype has been found to be associated with serious cutaneous reactions from phenytoin in this case. And this was a little bit surprising, perhaps, because this genotype was the 2C9, the same enzyme that I've shown you before affecting the metabolism of phenytoin. And the explanation was that because these people metabolize phenytoin very slowly, When you start them on phenytoin, the concentration of phenytoin will be much higher than in the rest of the population. And because we know that the risk of these reactions is concentration dependent during the initial titration phase, these subjects will be at a higher risk. And here you see that this is true for a variety of severe reactions, including stress, which is the worst of all because it's a systemic reaction. The study was done in subjects from Taiwan and Malaysia and Japan, but based on what we know from the incidence of genotype, Greek people or people from European ancestry are also affected by the possibility of having the susceptible genotype. I spent a lot of time in my presentation because I felt these data are of practical clinical relevance. Now you will forgive me if I will go very quickly through the rest of my presentation because it has some interest for research, but at this stage, not so much for clinical applications. So we do have some tests that predict adverse drug reactions. At the moment, to cut the story very short, we don't have a test which, with a clinically meaningful predictive value that will tell us whether the patient will be a responder or non-responder to a specific anti-epileptic drug. So a number of studies have been done. There were some hopes at the beginning when this study came out, actually in an important journal. Everything is fine except that these findings later on was found not to be true. And what this study suggested was this genotype which affects the expression of P-glycoprotein, which is a protein regulating the passage of some anti-epileptic drugs across the blood-brain barrier, affects the probability of response to anti-epileptic drugs. In other words, is a predictor of pharmacoresistance. And differences were found. Let's not. All the subsequent studies, and you see a meta-analysis in the next slide, and you'll see it here. This was the initial study. And then as more and more studies were done, you see that the point estimate came down, and the point estimate now is close to 1 with huge confidence limits. So as more and more evidence came, that effect became smaller and smaller and smaller, and now we know that putting all data together, the effect is not there. There may be a signal, but clinically not a major thing that we should be too much concerned about. However, we know that some genetically determined epilepsy syndromes are associated with mutations in drug targets. For example, this gene, which is involved in autosomal dominant frontal lobe epilepsy, has been shown to affect the response to carbamazepine on acetylcholine currents. GAF plus has been found to be associated with mutations in the sodium channels which have a reduced sensitivity to drugs. And you may argue, I mean, if one wants to argue, there are indeed situations, here are some examples, where using molecular testing to determine genetic defects underlying a specific epilepsy syndrome has clinical relevance. Autosomal dominant frontal lobe epilepsy would predict responsiveness to nicotine. Obviously, Dravet syndrome, you should avoid sodium channel blockers. Some of these benign epilepsy in the first year of life may support, if you have a molecular diagnosis, the decision not to start treatment because we know the benign cause of these conditions. The same is true, pyridoxine and folinic acid dependence epilepsy could be managed by replacement therapy. And again, of course, the ketogenic diet would be the treatment of choice if you made a diagnosis of of an epilepsy associated with GLUT1 deficiencies. There have been suggestions that mutations in the gene that codes for the sodium channel results in those channels becoming insensitive to sodium channel blockers such as phenytoin. And an original study suggested this could be true, but several other studies have not confirmed that, and I think I go very quickly, and perhaps I give you one of the many studies that now are coming to the same conclusions, and that is there may be some effect when you look at large populations, but overall, common polymorphism in sodium channel 1A, 2A, and 3A do not play a major role in influencing response to antiepileptic drugs. So overall, if you put all the wealth of data together, these are the conclusions. Although some studies did show came to some slightly different conclusions. This is an interesting one, again, very recent, using a marker of cortical excitability, and that showed that there is a mutation in the sodium channel that influences specifically a response to carbamazepine. But again, is not really showing a response to the clinical efficacy of the drug in people with epilepsy. And this is another study that I'm skipping just to indicate that there have been some reports linking mutations in genes coding for GABA receptor channels or the chloride channels influencing response to antiepileptic drugs. And again, I'm showing one example of many studies that came to this conclusion. There were effects, there were some p-values, but overall not significant. What is emerging more and more, and this might be the future, is that not a single defect, but a computer model that incorporates all the information coming from complex genotyping might predict an array of different genotypes that predicts a response to antiepileptic drugs. So this might be something which will apply in the future. SV2 hopes that it would identify mutations predicting response to levetiracetam, did not turn out to be true. And the same has been for people who try to look at potassium channels, and no mutation in potassium channel has been found to predict a response to antiepileptic drug. And again, if you go back to this publication, you find all the basic information of the many studies that have looked at that. So I'm 3 minutes ahead from my 30 minutes that I had scheduled. And I'd just like to close with one slide indicating future developments in this area. So far, genomic investigations have not led to a major breakthrough in epilepsy therapy, other than identifying some predictors of serious cutaneous, mostly, drug reactions. However, we should continue to look into this and incorporate genomic information in studies of new drugs, and most companies now are doing that. As we now know more about the molecular defects underlying specific syndromes, we may be able to now develop in the laboratory drugs which are specifically aimed at targeting those abnormalities. This, for the first time in epilepsy, would be really rational drug development, which we have never done so far. We can have models for the laboratory, for example, rats which are genetically engineered to test the effects of those compounds that we will be developing. And perhaps we could also identify biomarkers of epileptogenesis. And if those biomarkers could predict those subjects which after an insult are more likely to develop epilepsy, that would put us in the ideal position to test in the future anti-epileptogenic therapies. And again, there is also an opportunity to develop gene therapies. I stop here, and if you have any questions, I'm happy to answer them. Thank you.